there is so much urban mythology built around the use of antipsychotics. There's all kinds of mistakes, and I'll give you one example. One of the reasons that we use antipsychotics is for episodes of acute agitation, and we've talked a little bit about that. The reason people become agitated when they have organic brain disease and in a long-term care setting is almost never psychiatric. It's almost always neurologic. But sometimes, even with neurologic disorders, when people become especially so violent that they have the potential for being self-injurious or dangerous to the people around them, you need to give them something that will slow them down. And at that point, a judicious application of antipsychotics may in fact be clinically indicated. But what winds up happening is they're given, and then that's what you're stuck with. We know, for instance, that within 90 days, the positive effect of antipsychotics is equal to placebo. And yet people who get antipsychotics for good and proper reason stay on them. Okay? The approach to antipsychotics is they should always be looked at as temporary agents. They're there for a moment, and then they should be viewed as something you want to think about getting rid of. There are different ways of doing it, but the most common way is called gradual dose reduction. In common parlance, GDRs. What people also fail to remember is that for our dementia patients, sadly, tragically, their disease progresses. The average life expectancy of a dementia patient when they go into long-term care is between 2.5 and 3.5 years, and then they leave us. What's happening is these horrible diseases are eating your brain. One of the things that we teach is in this environment, you literally never see the same patient twice. Okay? Every day you see them, something is missing that wasn't missing the last time you saw them. Well, one of the things that can go missing is their agitation and psychosis. Okay? So you go on these things, and as their illness progresses, their brain and their psychiatry changes. Sometimes for the worse, but most often for the better. You know, it's hard to be upset if you haven't got any memories to be upset about. Okay? So what winds up happening is they go on these medications, and not only are they not removed for agitation, but even for general psychosis, you should always be reevaluating them, and at the moment where that begins to wane, get rid of the medication. That doesn't happen. You should always look at antipsychotics as a temporary answer to a problem. And the culture in long-term care doesn't really look at it that way. They don't address it. So one of the things that we say is it's always better to work down the dosage and if possible get rid of the medication regardless of what they've got. If you work at it, most times you can achieve it.